Hey, I'm James Bratcher, and I'm going to talk to you about dementia within the physical therapy practice. Dementia is a scary sounding pathology to treat, but to be honest, it's an umbrella term used to describe a combination of symptoms that can impair a patient's memory, focus, communication, reasoning, and visual perception. With every pathology, we have a list of challenges set in front of us to keep in mind. With dementia, it hits both patient and clinician. For the patient, we need to be aware that because they may continue down another stage of dementia, they may require a constant change in service they receive. With their cognitive integrity compromised, communication may be difficult. They may not be able to concentrate on what you're saying, they may not be able to properly communicate verbally, or they may not even remember you. Tying in with their memory loss, they may not trust you. And with us being a profession that requires trust on both ends, this can make things especially difficult. Most dementia patients are elderly, and with age comes conditions. On top of their cognitive challenges, they may not be able to see or hear you well, and ultimately, if they don't trust us or simply don't remember, they can't remain compliant to their instruction or plan of care you have for them. On the flip side, we have us, the clinician. You've heard it many times be that cool, collected professional, but in the end, we're still human. We need to remove any negative outlook that we may have toward the idea of treating a patient with dementia. Therapeutic nihilism is the thought of there's little we can do to improve their quality of life and slow their cognitive decline, so why try? It's a very closed-minded way of looking at things, and with a closed mind, you will ignore constructive criticism and knowledge and create a fear built from simple ignorance. And to be honest, this isn't constructive for a patient's treatment. So what can we do? Well, screening every patient that's 60 years or older for cognitive issues is a good first step to try to catch it early. Talk and communicate to not only the patient, but everyone they interact with, their friends, families, caregivers. Find out what they enjoy doing. Step into their world because it can be a tool used to help them become compliant with your program. Keep that same open and positive mindset that you have for patients with total knee replacements, concussions, and other injuries. Having this open mind will help you make an amazing first impression. And this is big because I don't have it listed, but the article stated that although patients may not remember who you are, they will still have an emotional memory. They may not remember your name, for instance, but they will remember how they feel about you. And this will affect how they act toward you as well. With most cognitive impairments, you must be patient and speak clearly and slower than usual, giving them time to process what you said. Being that we're not the only clinicians treating patients with dementia, it's important to work together with occupational therapy to slow the decline. So, the study I chose was a systematic literature review completed to determine if non-pharmacological interventions could delay functional decline in community-dwelling dementia patients. Their study selection was specific, in which they excluded any studies that dealt with other neurodegenerative diseases, was in a nursing home or hospital, or involved the use of drugs. As for their inclusion, they only chose the English language studies, and the participants had to be community dwelling with access to a primary caregiver, and there had to be a randomized control trial. 413 articles were originally found, but only 18 of them met the criteria. There were studies that focused on occupational therapy, exercise, and multifaceted interventions. Starting with the occupational therapy, the purpose was to maintain physical function, and it showed a positive increase with interventions being performed for 5 or fewer weeks. More geared toward our side, the results of exercise interventions showed a positive and significant result for functional performance. Aerobic exercises, resistance training, as well as balance and flexibility were trained, and the tests used were the chair standing test, timed up and go, and timed walk test. The multifaceted interventions involved caregiver training, collaborative care, advice on problem management, and cognitive exercise and psychomotor activities. But these showed no significant results within the patient's physical function. And as you'll see in the table later on, there was one article, however, that reported a positive increase, but it was in non-physical outcomes. Now, the table displayed shows the clinical significance with each article they reviewed through the effect size. So if you look over to the right, an effect size of 0.2 is considered to have a small clinical significance, while a size of 0.5 has a moderate clinical significance. With that said, it was noted that the 2008 exercise study for muscle strength showed the greatest effect size for physical function. The 2005 article for under other studies did have the largest effect size, but like mentioned earlier, it pertained to non-physical outcomes. So what do these results really mean? For exercise interventions that targeted larger muscle groups, there was an improvement to patients' ability to walk, transfer, and climb stairs. Occupational therapy's approach was more direct at involving the home environment as well as the patient's ability to perform. As clinicians, we must keep in mind that a patient's symptom will be worsening over time, so our interventions may have a window of opportunity that continues to grow smaller for us to slow their impairment. Now, when we look at the review itself, I like that the authors were very specific with their selection criteria, as well as going as far as to grade each article through the grading of recommendations, assessment, development, and evaluation, or GRADE criteria. On the other hand, the average sample size was about 100 participants, and despite all studies having the same goal, their outcome measures to measure efficacy were different. This could be improved by having a standardized outcome measure to keep the data consistent across the board. This is my reference page. If you have any questions, comments, concerns, feel free to comment and I will get to them in a timely manner. Thank you.